80% of stroke survivors experience some level of hemiparesis or hemiparalysis as a result of their injury. The typical recovery path of such patients requires them to perform hundreds of repetitions of task-oriented exercises. Similar to physical therapy, patients are instructed to do the bulk of these exercises at home. Also, like physical therapy, patients tend not to meet their rehab goals because exercises are boring and difficult to understand in terms of feedback. As a solution, movement-based games have been used to motivate patients to perform their prescribed exercises. A fair amount of research has been done on using virtual reality games in this way, and the results have been largely positive. However, in reviewing the literature, we noticed that there were few immersive head-mounted VR examples. Of these, almost none were designed for home use. We felt this was a great opportunity to improve quality of care, and so we began this study. Our objectives were to demonstrate that an immersive head-mounted VR system could be independently used by a stroke survivor as a clinically relevant adjunct to their home treatment. We had secondary objectives of being able to retrieve and analyze movement and usage data remotely. The study device included CogniviveVR software running on an Oculus Rift. Data was transmitted to a secure cloud storage and processing system. Data could then be reviewed and analyzed using Cognivive's browser-based clinician dashboard. Our games measure patients' physical and cognitive abilities and encourage them to extend those abilities through gameplay. As the system learns about the patient and the patient progresses in their recovery, we adjust the difficulty of each activity to promote further progress. Here's an example. Here, the patient must hit a ball with the paddle that they hold in their affected hand. The activity is designed to improve the patient's lateral and vertical ranges of motion. As the ball returns, it follows a trajectory that will place it near the edge of the patient's range of motion. The patient reaches to strike the ball, effectively completing a rep of a rehab exercise. Thanks to myriad accessibility features, such as the aim assist demonstrated here, the game remains fun and rewarding, regardless of a player's physical abilities. The study participant, shown here, was a 64-year-old male who had suffered a pair of hemorrhagic brainstem strokes 5 years prior to the start of the study. The patient continues to have weakness in his right arm, including deficits in sensation. Data was successfully monitored and analyzed during the study to reveal that utilization was consistent with common at-home therapy goals. Using a movement smoothness metric developed specifically for upper extremities, we observed a significant improvement in movement smoothness across the study period. Note, values for the SPARC metric are hard to compare across different upper extremity tasks, but a normal value for a point-to-point reaching task is approximately -1.6. In summary, we have shown that head-mounted virtual reality can be independently used by a stroke survivor to practice rehabilitation exercises at home. Our study participant used the system with clinically relevant frequency and appears to have improved the smoothness of his motions with his upper extremity. This study was a proof of concept demonstration, and as such, we did experience some minor technical issues. However, those were largely fixed remotely. We have since resolved our greatest usability problem by porting the system to a standalone VR headset. Here, we see the revised version of the system using the standalone Vive Focus Plus. A mobile app was developed to provide clinicians a way to see what patients see in VR, as well as control the experience. The system content was also expanded to include a new setting, and we are actively recruiting both clinicians and patients to evaluate the system.